Hello, everyone. This is Dr. Angela Lin. I'm a medical geneticist at Massachusetts General Hospital. And as you know, I'm the co-director of the MGH Myhre Syndrome Clinic. I have an interesting talk today because it's not about a medical problem. It's about the search for guidelines. When you meet a doctor who cares for you, either as your PCP or as a Myhre Syndrome specialist, you must wonder, how does this doctor know what to do? And it begins with one patient, second patient, third patient. We build up our experience. And I personally very much appreciate what you can teach me about yourselves. So that process continues and continues. And at some point, there is sort of a critical mass, and that's what we call guidelines. But guidelines are not just this idea of what should we do. There's something called evidence-based. Makes sense, doesn't it? Before you give these guidelines, you want to have the evidence for it. So I'm going to tell you how we're going to try to do that for Myhre syndrome. It takes a long time, and I know people are literally demanding this, but it's going to take time. So here we go. So the purpose will be to review the process to create evidence-based guidelines for Myhre syndrome, discuss the importance of systematic evidence review, describe the approach that a small support group like ours can use, which differs from a larger organization. So it's kind of a weighty talk, and you might have to go back and listen to it again, but I'll go slowly. So evidence. How do doctors learn evidence? How do we experience it? Who, how many, what, and when? It all begins with the first patient. We call that a case report. And some of you may say, you know what, I was reported in a case by so-and-so. So it begins with a case. And then when you have several patients, you call it a case series, a collaboration. The paper that I wrote about cancer in Myhre syndrome is a case series. And then after a while, you say, you know, compared to other people or compared to other disorders, what we have in Myhre syndrome is such and such. And we call that observational. There's no animals involved. A case control, we're comparing what we see with another group. And this is my little graphic here. And at some point, when you have enough data, you would say, well, compared to the entire population of 10-year-olds or compared to the population of 40-year-olds, this is what we see in Myhre syndrome. So currently, we don't have that high level. It's called epidemiology. So think of the word population, population-based. Now, if you're fortunate enough to develop a drug for a condition, you can compare treated and untreated individuals. And the way it's done is a randomized control study, an RCT. What we often do, though, in the meantime, is we get together, as we will be doing with our Myhre group, and we develop what's called a consensus. This can be done within the specialty of the heart, the syndrome group at the NIH, something national, and you create a paper that's called a consensus paper. So the real ideal, the highest level, is something called a systematic expert consensus process. And there are different technologies, there are different programs. Delphi, GRADE, which is used by American College of Medical Genetics, AGREE, the modified Delphi, and these are just names. But the reality is sometimes once you attempt these, you realize we don't have enough evidence. And so you go back to doing an expert consensus statement. Again, you want to go to the highest level, but you may not be able to. So let me tell you about this in a different way. So this is about evidence and recommendations. So you can have a disorder like Myhre syndrome, and you might have some case-controlled studies, case series and reports, cohort, randomized controlled trials. Remember I was telling you there's higher level of evidence, right? And all the way at the top, you might have a systematic review. But what you have is an increasing quality of evidence, but you may not have, it may not match the feelings. Here, let me try to show it another way with this Venn diagram. You have clinical expertise, which we're gathering. You have the patient values and preferences, that's you. And then you have the best evidence. And at the intersection is what we would call the evidence-based medicine. And you're in pursuit of the best possible outcomes. This is maybe where we will end up. There's another style of doing this type of review. And it's like a series of circles. You start with your ideas and the people, and you decide what you think. Then you go back and you rate your opinions, when to do this, how to do this. Then you go back and you compare. And the ones that you have a lot of agreement on, it's usually like 75%, 80%, you keep them. And then the ones that are falling out, there's a lot of controversy, you go back and you start over again. So it's a series of events, it's a series of interactions. And you can imagine that this can take a long time because you could start out and say, well, let's get back together again in 1 month. Well, we have to do another round. And so before you know it, you're easily up to 6 months. Another way of showing this is this familiar, it's this multicolored set of steps, if you will. And let me take you across the x-axis, the size of the treatment effect. Suppose you are doing a study and the treatment effect is very strong. Benefit is much greater than the risk. Class 2B, they give them numbers. Benefit outweighs the risk. Class 2B, sort of is better. And class 3 are the ones where you actually have no benefit or harm. And these are the ones you really have to be careful of. On this axis, on the y-axis, it says estimate of certainty, the precision of the treatment. So a level A study would say multiple populations evaluated, data derived from multiple trials, strong, you can feel that, right? Level B, limited population evaluations. And now by level C, it says very limited populations evaluated, only consensus opinion. So guess where Myhre syndrome might fall? Probably at this level. We have a small population. We can't do anything about it. We're trying to get larger numbers. At Mass General, we've seen slightly less than 50. And the studies are coming out, but even my big study, I'm still working on it. And so how we will rate it, I doubt it would be something like this, but whether it would be maybe class 2, it's going to take some time. Here's another table. It's actually showing the same information, but in a different way. And over here are these different types of studies and the evidence quality. Well-designed, randomized control studies, diagnostic studies on relevant population. These are the articles you hear about that are published in the New England Journal, and they're used to perform evaluations of trials. Diagnostic studies, observational. So this is what we do, observational studies, we actually don't do this. We do D, expert opinion, case reports, reasoning from first principles. And you may wonder, why don't we do this? Because we don't have a drug to trial. But you can also do trials based on things other than drugs. You could do a trial that says, I'll just make something out. If somebody were to check their calendar once a week, they somehow do better. I just made that up. But that would be a trial where you can compare people who do it and those who don't. And then this is X, the exceptional situations where validating the studies can't be performed, and there is a clear preponderance of benefit or harm. So these are people. This could happen when somebody is in the hospital, extremely ill. You don't have an official study, but you know a certain drug will work, and they can make an exception for that. There's also times where we know it would be harmful, and you have to deal with that too. So you judge them, the studies then, by the preponderance of benefit or harm and the balance of benefit or harm. So here you have strong recommendations, option. And down here, you might make a strong recommendation or actually a contraindication. So which method will work for us? Evidence-based guidelines, committee-based guidelines, expert review. So what I did is I created this, by the way, I had given this as a talk at the American College of Medical Genetics meeting in March, so it helped me prepare for this meeting now. So what I did is I searched around to look at other rare syndromes. So you're not going to see me talking about cystic fibrosis or myocardial infarction. I'm looking for common rare syndromes. So Williams syndrome is a disorder, which we know there's a gene, and they created gene reviews, as did we in 2017, okay? So they have a paper that's called a healthcare supervision paper. So it's a higher level, and that was published in 2020. Pitt-Hopkins syndrome, very rare disorder. They have a gene reviews from 2018. They came up with a consensus statement. Here's Myhre syndrome. No official guideline, but we had a gene reviews from 2017, and we updated it in 2022. Good for us. Gorlin syndrome does have consensus recommendations. They got together as a group, and that was done, I think the last time was done like 2017 maybe. And here's some more. Here is DeGeorge syndrome, and they do have a consensus paper. Turner syndrome. So I just came back from the guidelines meeting. It had been done in 2017, and we just did a new one now. And Klinefelter syndrome. And I'm just going to name some of these. These are metabolic diseases: mitochondrial, Fabry's disease, urea cycle. They actually have guidelines. To their credit, they got together and they worked really hard to produce evidence-based guidelines. So there's this one methodology called GRADE. It's not really ideal for rare syndromes. GRADE means grading, recommendations, assessment, development, evaluation. And the GRADE analysis may not be able to answer the question if your data is insufficient, if your N, the number of patients, is too small. For example, you say, what is the genotype-phenotype correlation? Well, we have some ideas about that for Myhre syndrome, but we don't have enough data yet. And there's something called the modified GRADE. So at this conference that I attended, and I need to update it for 2023, we tried to use this GRADE evaluation, but we really did not have enough data to complete it. Now notice these colors. I'm always showing you these diagrams of different colors. So this is something called Delphi. And class 1 is strong recommendation. All the way at the bottom here is class 3, no benefit. And they use class 3 also to indicate harm. And then we have the level of evidence, level A, high, level C, LD, C or lesser. So I think you get the idea. You're scoring something based on what you want to say. How strongly do you want to say, and do you have the evidence to back it up? And this is done electronically. So you circulate these questions back and forth, and you ask questions. Then you try to get together. 80%, minimum 75% is considered agreement. You don't have to have 100%. And then you have another round of voting, and then you come up with potential recommendations. You use something called a Likert scale, where 1 would be strong, and then 2 would be maybe, and then you score it that way. So there was a paper that I liked called a modified Delphi study to identify the features of high-quality measurement plans and healthcare improvement projects. What this illustrates is this has nothing to do with rare syndromes. This shows you that Delphi, this method, it's a methodology for evaluating different research in many different spheres. The difference between the classic and the modified is that how the questions are generated. As I'm speaking now, this talk is more relevant, this page, to the providers I'll be working with. So a modified Delphi is directed by the leader, whereas a classic Delphi open-ended. So the leader would sort of drive the process towards consensus. You don't enter this to have arguments. You don't enter into this process to see what kind of debates can you find. You want to bring it to consensus. This is kind of elaborate, but it's just showing you, you've got participants here, you've got their questions. For this particular study, they had 104. And the point is, you start out with 76, 62 identified, 14 nominated. You have to sign a consent form. Maybe everybody doesn't want to. You start by completing the first round, then another round, and then another. And you can see how it just keeps going on and on. And the idea is to really drive it towards consensus. So guidelines for rare syndromes, this is lessons from a learner. I am a learner, folks. I am by no means an expert. But what I've started is by saying, engage the community of providers and consumers. And we are doing that right now. The timeline is at least a year. I know people would like it to be 6 months, but it's just not going to happen like that. We need to get complete studies, and there are a couple of them that are out there. I can't tell you what they are, and we're trying to bring them to completion. And once you get going, you have to really focus. It's very hard for physicians to take care of people, to do their research, and then to do this kind of a process on top of it. So you have to be understanding of what's going on. And then we'll select the methodology. I'm going to probably use a modified GRADE. We'll send invitations. I'll probably invite almost everybody in the board. Select the leaders, coordinator, obtain funding, conference, and a coordinator. So obtaining funding for this is unlikely, but it would be great if there could be a volunteer from the Myhre Syndrome Foundation to help be the coordinator. And I think I may know who it will be, but I don't want to reveal that person's name yet. But the point is it would help to have an administrator, somebody who will say, Okay, folks, you do this. Now you bring it back to me. Now you do this to set up the meetings, to set up the reviews. So you select the participants from the centers with expertise, and that's easy. Create study section groups, heart, joints, whatever. Determine the logistics. It would be cool if we could start it in January so that when we meet in July for the conference, we would be there in person. Not all the doctors will be there in July. I don't know if you know, there's going to be a selection of people. But what we might be able to do is create some sort of a Zoom meeting, maybe not there in Philadelphia, but maybe once we get home. You'll use email, video conferencing, and then manuscript writing is really hard because you have to pool all this and write a paper. Now, interestingly, one of the good things about manuscript writing is I know how we can get it accepted somewhere. And I'll tell you at the end because we have a way that we're going to create some manuscripts. Okay, back to this. Evaluate the quantity and quality of the literature. It's great if you can get an official librarian to do your searching. So all doctors do PubMed. Some people use something called Scopus. If you have the ability to assign a librarian to say, here's what we want to do. You want to search on every article involving Myhre syndrome. I personally think I have that. I personally think I've collected the world's literature, but I might be missing something. And you assign the literature to the study groups. So here's the experience that I've had. I worked with the Costello group. This is another rare syndrome, not as rare, 1 out of 300,000. There's a support group, and I worked on a project where we created an expert opinion paper. And it looked like this. So here I am down here, and I was involved with the heart. And this came out in 2019. So it's not an official evidence-based guideline, but it comes pretty close. Then I told you I've been working with the Turner syndrome group, and we met in Denmark. I met with them in 2017, also 2023. And the paper that we created looks like this. So lots of authors, lots of people, and clinical practice guidelines for the care of girls and women with Turner syndrome, proceedings from the 2016 Cincinnati International Turner Syndrome meeting. And the way it is written, it's very detailed and it's very technical. So we say, we recommend considering a diagnosis of Turner syndrome in phenotypic males with a karyotype containing 1X chromosome and complete or partial absence of the second sex one, blah, blah, blah. And so you go through this as recommendation 1, recommendation 1.2. So it's very detailed. I'm currently working with a group under the leadership of thoracic surgeons because we're looking at trisomy 13 and 18, which are severe chromosome problems, and we're trying to determine what should be the management of these babies when they're born. Should they have surgery? This, in fact, is going to be an expert consensus document. We follow the modified Delphi. We did it in a very official way, and we were fortunate to have someone who was paid to be the administrator. This group, the thoracic surgeons, know what they're doing. They've written papers about it, and they have a manuscript that they wrote about tetralogy of Fallot, which has nothing to do right now for Myhre syndrome, but it's important to the doctors who's listening to this to have a model. You don't want to imitate something. You don't want to have plagiarism, but you want to see how did somebody else do it, and that helps. So now this brings us to Myhre syndrome. So I'm going to start by looking at this, the Myhre syndrome guidelines that we have. And we have evaluations. So we have some general ideas. And those of you who've read it many times, you understand that it's very useful. We have some suggestions about treatment, about things to do, but they tend to be sort of general. For example, obesity. Consider referral to a nutritionist for interventions. May be difficult to manage. We don't say reduce your calories, don't eat this, eat that, etc. It's just a very general guideline recommendation. And then for surveillance, we're telling people what do you need to do to monitor for growth for the heart. So I've already been thinking about how we could conduct this, and this is my guideline, my guideline to the guideline, but it's pending. So we'll have leadership, experts. The co-authors will be the people from the professional advisory board. We don't have money to pay a librarian. Hopefully we will be able to have our volunteer help us with coordination. And we are engaging you right now. This is my attempt to engage people at least 6 to 8 months in advance. And the timeline is to sort of start what we're talking about now, make some headway to July. It would take really quite a bit of time to create the actual manuscript and publish it in the spring. Now, the good news is that there will be a special issue of the American Journal of Medical Genetics. It's called a seminar. And I proposed it to their editors, and they jumped on it. It won't come out to 2025, but it'll give us time to accomplish some of this. So it's really exciting. And it does mean that we will have a place to have it published. And so we'll do the literature review. Everybody has to have DNA-based confirmation. That is mandatory. And after 2012, which is when the gene was discovered. Case reports, we'll look at them as part of sort of background, but not for decision making. So for decision making, we need to have a series where you're really at least over 10 or 25 is even better. So these, we've got some things in preparation. The Yang paper was published. Tim Van Dam and Bert Kyrward are working on theirs, and mine is also in preparation. Randomized control trials, not available yet. Gene reviews, we have that. I'll assign the literature to different groups, genetics, cardiovascular, brain, et cetera. And then I'll look at how other people did. I'll look at my experience with the trisomy 13 and 18 group to see how they did it. And so here's how it might begin. Phase one might be idea generation. Pre-planning, develop the topic, create the outline, select the experts, divide into subgroups, select the chair and the writing group. This is actually doable. This is something that we could think about doing maybe in January. And there's also a steering group, means that these are the people having oversight over all this. Literature searching, it's actually not going to be too hard. As I said, I have all the articles right now, and then we need to search to make sure we haven't missed anything. Gene reviews will sort of guide us with some phrasing and the topics, and the experts will submit statements. So you will submit a statement that you want to prove or disprove. The assessment of the statements is when you sort of begin the Delphi process. The statements will be circulated, there'll be voting, writing statements, voting again, this kind of cycle that I told you about. So phase two is the writing and discussion, phase three is reassessment, and you might have to go back and do it again. So here's an example of what I think would be a statement. The number one, the diagnosis of Myhre syndrome is established in a proband, a person with suggestive clinical findings, and a heterozygous, one copy, pathogenic or likely pathogenic variant in SMAD4, some type of molecular genetic testing. The recommendations, I would think this would be extremely strong, 5 out of 5 level of evidence. I think it'll probably be high. Another question would be, depending on the phenotype, molecular genetic testing approaches can include gene-targeted testing, single gene, multi-gene, comprehensive genome testing, exome or genome. And again, I think these are almost self-evident. These are things that we have to do. There is nothing here that has failed or has been unsuccessful. And this is just some photos of a lovely young girl who's cared for my colleague. So here's one that might be a little more controversial. All patients with Myhre syndrome should have a formal consultation by medical geneticists at the time of diagnosis. So this is my bias. I'm a geneticist. I think this is a strong recommendation. However, there might be people who say, this is not practical, Dr. Lin. This is not practical if you live in a certain country, you don't have access to care, and I get it. So we'll discuss it, right? There are times where you can make a strong recommendation, but then you come up with your level of evidence, which is weaker, and you can do that. They don't have to be exactly the same strength. Patients with Myhre syndrome benefit from care coordination of an interdisciplinary team. Again, I think this is strong. I think this is the way it has to be. But in fact, it may not be realistic, again, depending on people who live elsewhere. So it might be, the level of evidence might be consensus expert opinion. All patients with Myhre syndrome should have a baseline cardiology consultation with echo. I don't think there's any disagreement with that. And then the level of evidence would be, we would have to prove that we have a reason for saying that. I'm going to sort of flip through the others, which is using CTA or MRI for the aorta, repeating the echocardiography. Let's see what else we have. And this is an iterative project, which means you start out with some ideas, then data might come out, new research, and suddenly you're going to change your mind, and that's okay. And so again, this is using the organ systems that were present in the gene reviews, respiratory, GI, developmental. And this is how we will create our little subgroup discussion. I showed you this diagram before you start out. You agree, it might be a really fast progression. You might have something, oh, everybody agrees with this, and then you're done with that question, but you have a lot to do. Cycle to participants, recycle, recycle, rate manuscript, revise, and submit. So we will review with the community. So to be determined is whether we will invite somebody to be actually a co-author, such as Kate, whether we will have this reviewed by the board of directors. You wouldn't be co-authors, but could be included and acknowledged, or certainly reviewing draft manuscripts. But I assure you that the community will be engaged. And so the thing that I'm really interested in is how you disseminate it. You have to market your product. Of course, we have Kate Weirs, who's terrific at this. You post it on websites, host a webinar, right? We could do this as a webinar eventually, seminars in the community. So this is what I do. I present my material scientific meetings. You anticipate a study of compliance. This is kind of interesting, is once you generate guidelines, 5 years later, you should go back and find out, is anybody using them? So you could find out, you design a survey to ask people. And in fact, my colleague at MGH, Stephanie Santoro, who studies Down syndrome, did one to look at the adherence to guidelines for Down syndrome. It was also done for Turner syndrome and found to be very poor. So you have good intentions, doesn't always work out. I'm also working with a group called NORD, which is the National Organization of Rare Diseases, and we're creating a paper about how to do guidelines. So that's coming out. I don't need to go over this in detail. In conclusions, for a rare syndrome in need of guidelines, compare the gold standard to the pragmatic reality. Don't let perfection be the enemy of the good. We'll certainly start out by using a modified Delphi method. We're not going to wait for a randomized controlled study to begin. And I will define who the leader will be. And it doesn't have to be me alone. I'll probably have a co-leader maybe. And regardless of methodology, reevaluate every 5 years. I hope this made sense to people. I'm sorry for being a little bit hoarse, and we can discuss it later on. Take care.